Hi, everybody. It's Dr. Becker. This gets started with Chapter 1. Prescriptive authority is a legal term that refers to your legal right to prescribe drugs. Obviously, this is something that sets you apart from a bedside or RN level of practice. Each state has different rules and regulations regarding prescriptive authority. So the degree of your prescriptive authority can vary for non-physician providers. And sometimes you can have limitations tied to oversight by a doctor, either an MD or a DO, which is quite frustrating. We still have several states in the country that require some kind of authorization by a physician in order to have prescriptive authority. So it's important, whatever state that you're in for practice, you know what your state's prescriptive authority is within your state board of nursing. Here in South Dakota, we are independent practitioners and we do not have any physician-tied oversight. Again, there's the difference between independence or without limitation. A provider is not subject to supervision or collaboration with the physician in order to prescribe. Without limitation means that as a provider, we are not restricted from prescribing certain drugs, including controlled drugs, with the exception of Schedule I drugs. Those are often limited or prohibited depending on what state, what practice you're in. Those are things that are oftentimes reserved for anesthesiology. So many of us will have independent parts of our provision and without limitations outside of level 1, which is what we have here in South Dakota. Again, it's determined by your state law, which is reflected in your state board of nursing. Regulation of prescriptive authority is under a board then that sets its rules and regulations. For like the state of Oklahoma, they have a different an Oklahoma Pharmacy Registry Board that also regulates for physicians and providers, as well as the State Board of Nursing or the State Board of Medicine. Full prescriptive authority is what we seek for all APRNs across the board, across all states is what we are shooting for. I would love to say that this might actually happen within my lifetime. I don't know. We'll see. The argument for full prescriptive authority is that we're educated to practice and prescribe independently without supervision. There's no program in the country that's going to prepare a nurse practitioner or a CNS to come out into practice and rely on collaboration directly, or supervision, I should say, directly with a physician. The reason we have our national exams are to validate the ability to provide safe and competent care. Licensure ensures compliance with standards to promote the public health and safety, and limited prescriptive authority creates numerous barriers to quality, affordability, and accessibility for patients to receive care. This is very true in rural areas. We have been able to fill the gaps and fill the voids to the lack of physicians by supplementing primary care with advanced practice providers and like nurse practitioners in particular. And if we are limited in our prescriptive authority, it doesn't do you a whole lot of good to go out there to a place where there aren't physicians to practice, when you'd have to have the supervision of a physician in order to truly practice because you're limited in your practice authority. Prescriptive authority and responsibility requires, prescriptive authority requires great responsibility. It always reminds me of the Marvel movies when, like people will say something like, with great power comes great responsibility. And that's very true as a prescriber. You will find in practice, when you're independent and you're out there, you're writing your own drugs, your own orders, your own medications, it is intimidating because you are going to feel that weight of that responsibility on you. It is something that we should never truly lose. We have to have the humility and humbleness, right? Because we want to be able to always honor and be in awe of this responsibility and this power that we have to influence our patients' lives. But it can't be something that you are paralyzed by fear in order to make a decision to prescribe something. So we just have to take it that there is great responsibility and we need to be respectful and humble before that. but also be confident in the skills that you're learning. And I would say that this course is one of those first steps to really understanding the safety and how to prescribe safely. Safe and competent practice of prescribing and managing medications requires a sound understanding of drugs and the conditions they manage, which is very true. As we spoke about in orientation, as an example, this is not just a course that is simply advanced pharmacology. This is advanced pharmacotherapeutics. So that means not only do we have to know the drugs and understand how they work physiologically, but we also have to understand the anatomy and physiology of disease states so that we can put all that information together. We can recognize a disease, we can understand the disease, so we can prescribe safely and competently. We know why we're prescribing the drug, what mechanism of action we're hoping the drug achieves, how we're going to know if it's working, and how we're going to know if it's not, and what to do with the side effects should any occur or an adverse reaction occur. So that is that first step now, is this course that y'all are taking, because you are now going to have that chance to dive deep into pharmacotherapeutics. All right, next we're going to jump into Chapter 2, Rational Drug Selection and Prescription Writing. This is a fast chapter. This is an example here of what old prescription pads used to look like, but it's a good example of what information is needed in order to prescribe. Again, you're going to have what clinic or business you're from, what your name is with a correct address and a correct phone number and fax number. So your information needs to all be on there. Then you have your patient name, the date of the prescription. It is good practice to have on the prescription allergies for two reasons. One, whomever is prescribing it can do that check with you. And two, it makes sure and prompts you to make sure you know what their allergies were. Oftentimes, you need identifier of the patient, which is typically a date of birth. And then you write the medication, the strength, the quantity, how you use it, whether or not there's going to be refills, what your DEA number, what your NPI number is, how they could get a hold of you, etc. And oftentimes now it also is indication of use. So you'll write something like Augmentin for tonsillitis or whatever, and then, take 1 tablet twice a day by mouth with food, 10 tablets, no refills, and all of those components would be there. So it's very important that you know what the components are to be safe prescribing. I think this is really neat. This is how they used to look like way back in the day. These were like banknotes, or they look like dollar bill paper that you can see here. You'd have your kind of stub, on the side. They would tear it off and then send it in, and this had to be a verifiable prescription that way. Go back down here. All right. The responsibility of prescribing. Giving medication and prescribing medication are two very different things. It's a simple statement, but I love that this is in here, because it is very different to prescribe the medicine, right? I could not tell you how many times I look back now in my nursing career, bedside nurse in the ICU, for example, bedside nurse in med surg when I did that. And I would just be ready to roll my eyes, because I would call a provider and I'd be like, can't you just give me an order for Tums or Tylenol, or they just need a pain pill, or whatever the case may be. And there would be hesitation, or they'd be like, well, let me look up some things and I'd call you back. And I remember, times of being like, oh my gosh, how hard is it to write a prescription? Just give me what I need, right? And I'm sure you all have been there and done that too, as a bedside nurse or clinic nurse or what have you. But when you are prescribing the medication, it is a different thing. There are many different issues to consider when writing the prescription, right? You have to make sure it's appropriate, that they can handle it, that there's no contraindications, that there's no adverse reaction that you need to desperately be worried about, etc. There's a lot of things there that you worry about as a prescriber that are, minutia of details that you're responsible to know. The responsibility of prescribing falls on you. So when you graduate this program and you become an APRN, and you get your prescriptive authority. Hopefully, if CNSs are listening to this, that time comes soon. But for nurse practitioners, your responsibility if you're prescribing is going to fall solely on you. Here's some of the main components of how to be responsible, how to have good, prudent, and deliberate decision making. Okay. This first one, I talk a lot about in practice. I talk a lot about it when I have students. It's very important. You need to only prescribe when you have a documented provider-patient relationship with the person for whom you are prescribing. So, if you want to prescribe for your neighbor Susie, who you've known for 10 years, who tells you her entire medical history, and you feel very confident that this antibiotic you want to write for her is going to be safe, do not do that unless you have a documented provider-patient relationship on record some way, somehow. Okay? We call this fence post prescribing, is a term you may hear. It is what people can get in trouble for. It is something that can sink your ship. Okay? Because if you look out there, you're going to find those rare stories, but they do happen, where unfortunately you did prescribe something over the fence post for the neighbor who you've known all your life. She's practically a second grandma. Well, guess what? That 1 in 1,000 thing happened. She had a horrible reaction. She got deathly ill. And now the kids who don't know you from Adam sue because their mom had this horrible reaction or died, and they could trace it back to this fence post transaction that just occurred. And you will have absolutely zero leg to stand on. You will lose every time because you are practicing outside the standard of care, and you will lose. The same thing goes for spouses, for children, for mom, dad, brother, sister, family members, period. I would argue always avoid being involved in your family's medical care. If there's a way to defer it to somebody else, you ought to do so. Okay? So there's never a time that I think it's the right thing to do to just prescribe something for your husband or your wife, or just prescribe something for your uncle. No, unless it's a documented relationship of record somewhere. And even then, even if they're your documented person, if you can get another provider to provide their care, you ought to do that. It's just best practice. I've had 2 situations in my life where a family member that I would consider to be a close family member, in each instances, one was an aunt and one was a cousin, and we crossed paths where I was part of their care. And both times I was as a nurse, and both times I changed my assignment or asked to not be involved and stepped away from being their caregiver. It's best practice. Again, I'm harping on this a little bit in this lecture, but you guys are young and just starting your journey, and I want you to hear this. Get it out of your mind to do this. I remember there were some times where I would witness nurses asking the doctors or the providers that were on like our floor, rounding on patients, to write them a script. And numerous times the doctors or providers would do that. And I always thought, well, that's so nice of them. I have never done it, you guys. I'm sure there have been nurses or staff members I've worked with that think I'm just a mean old witch, but I don't do it. I've been working 5 years alongside a nurse who I know and trust as a nurse, and they've been like, I just can't get to the doctor. I think I need a Z-Pack. Nope. I'm not your doctor. I'm not your provider. I don't prescribe outside of documented patient-provider relationships. And I've said those words. I just do not do it. I'm so sorry. The other part to this then is you need to document a thorough history and physical exam. Include any discussions you've had with the patient regarding the risk factors, the side effects, and therapy options. You have to document. It has to cover your behind, right? But you need to document that you did a physical exam, that you saw them, that you made a decision, you got the appropriate information that was needed, and you did that. And then you document your plan. It is, even if it's an outpatient clinic or the ICU, either way, you document your plan. I'm going to give Augmentin because A, B, and C. If that doesn't work, I would consider next options. I feel likely that these are the bugs that I need to be covering, the rationale of how I came to decide that's the drug that I was going to give. You need to be able to document that, and you need to be able to build your case why you did what you did. Especially when you get outside of first line therapies. So, for example, let's go with that group B strep pharyngitis or group, strep pharyngitis. I have 6 examples running through my head. If that happens and the standard of care for most people is Augmentin, and there is a reason that you are deferring or you are veering off from that standard choice, that first line choice, maybe it's that penicillin allergy, then that needs to be clearly outlined and understood. Patient has a penicillin allergy, thus I'm going to use whatever next. Or maybe patient has had 3 previous episodes of Augmentin use with profound diarrhea and has requested not to have Augmentin, thus I'm going to go ahead and use Ceftonir or whatever the case may be, and that's your reason why. If you consult additional providers, note that you did so, okay? I did this in my time often when I would cover urgent care or the ER, but like a walk-in clinic urgent care. I worked in a smaller community. We had a great team of people, and the specialists took calls. They were great to work with. I had a gentleman I remember that was in his 60s, overweight, a really bad diabetic, who had just the most awful, funky ear infection that was fungal, and it was awful. And I was like, this is not my forte, right? This is not something that I see every day. I'm not sure exactly what I'm treating. It's Friday at 6 o'clock. It's going to be 72 hours before anybody's going to see him again as a specialist. I don't want to miss it. His sugar's 400. He doesn't feel good. I was very in a position where I was like, I'm not really sure. That one sticks out to me. And I called the ENT on call and walked through that with him. He was lovely. He was great. He gave great examples. We did some different consulting and collaborating, and he helped me build this plan of care, which was great. He got him an appointment on Monday morning. He did all the right things. And I documented all of that because I was like, this is what I've done, and this is why I feel comfortable with this plan. And then I also documented quite clearly the instructions that I gave to the patient on when to seek further medical attention and what I would be worried about and why I would want them to go to the ER over the weekend if something was going wrong. And so a typical walk-in clinic took over like an hour and a half plus for this man was in this walk-in urgent care as I was working my way through this. And I know I was irritating other providers because I was moving pretty slow that afternoon, but I needed to make sure that this was well taken care of for that patient. So I just share that as an example because I want you guys to think about these things as we're moving through this course, as we talk about clinical scenarios. I want you guys to be thinking of these things and keeping this in the back of your mind. When I give you a scenario and I say, how would you treat Mr. Smith? Then think in your mind, what's my rationale? How am I going to document that? These are important things. There are many factors that will affect your drug selection. In a perfect world, when we teach you clinical practice guidelines, when I teach you evidence-based practice, and we say those things, that's a perfect world. And as you and I both know, that does not exist. It just doesn't. And there's a lot of factors that are going to guide you and sway you into what you're picking for your patient. The first one is cost. I mean, if they can't afford it and they can't go get it, they're obviously not going to take it. Sometimes the newer drugs are out there, they're cost limiting. If for things like if they're a veteran through the VA, sometimes if it's non-formulary at the VA and there's the ones that pay for their medicine, you are not going to get it approved. So they either have to pay for it out of pocket or you have to use the second line that wasn't your first choice. There's guidelines that'll tell you what you should and shouldn't do that are considered your standard of care that we should follow that's going to impact your choices. It would be really hard to come up with a drug that does not exist on a society's guidelines or some standard of care that you just came up all on your own without having a really valid argument of why you have to go that route. And if you had to, fine, but you have to be able to document that. You have to also know your availability. Sometimes there just aren't medicines available. They don't carry it routinely and you're not going to get it for a week. Or maybe they've been on that drug for a year and now there's a crisis of that drug and you just can't get it anymore. Obviously, the interactions of how the drug interacts with the other drugs the patient's taking is a huge role. The side effects, the risk and benefit of those, You'll find in this course we talk about this. Sometimes we actually find that a drug was given for another purpose, but the side effect actually turned out to be a good one, and now we use that drug for a different purpose. Now we can use that drug specifically for the side effect. Obviously, allergies, what their liver and kidney function is huge. And then the need for monitoring. The perfect example for this is warfarin or Coumadin. It is a pain for some people. Some people, it's very hard to find a therapeutic dose for them. And for maybe the first months or the first year, it requires frequent PT/INR monitoring. And that is something that they may say, I'm not going to do that. If I have to come in here every week to get my finger poked for that, I don't want to do it. Then you're like, well, maybe it's time for Eliquis or apixaban, the alternative options for you. Again, part of your prescription, please read this and know these. They all need to be in there. You will find with electronic health records that oftentimes you are electronically prescribing your drugs. So you're typing it into Cerner or Epic or whatever platform you have, and you submit it electronically to the pharmacy. This is phenomenal. This saves you a lot of time. The patients love it. By the time they discharge from the hospital, sometimes the pharmacy already has their scripts ready to go. It is great. When it works great, it's awesome. When it doesn't work, it will give you an eye twitch and early gray hair. If any parts of these are wrong, the pharmacy cannot accept the prescription essentially. And so sometimes that's a glitch on you as the user, you ordered it wrong, and sometimes that's a glitch from the electronic side of things, or the computer's broken, or something's not being transmitted correctly. Whatever the case may be, all of these parts of the prescription are there and they are necessary. Remember, we do have different types of prescription. Again, in today's world, far and away, you're going to have e-prescribing, which many, if not all pharmacies, it seems, has this. I've still run into some in smaller town America, but for the most part, major health organizations and major cities all have electronic prescribing. However, this can limit certain things like certain opioids or certain controlled substances. We can still have options for the telephone, and that can be done by a nurse can call in a prescription under your name. But remember, that's probably not the safest and really should not be done routinely. And then written ones are your next safest option. Obviously, if the computer system goes down, you write a written prescription, and most times that's, or all the time, it has to be on some kind of prescription paper as a safety mechanism. So that's types of prescriptions there. And very quickly, Chapter 3, promoting positive outcomes of drug therapy. Medication education is by far and away the single most important thing that you can do to get your patient to adhere to your plan. When you lack in communication, things go very badly, and this is essentially education. So this is your way to get them to comply and to buy in, to adhere to your plan of care. This is your opportunity to explain the importance of the medication. You have to assume, unless they tell you differently, just assume that they are medically illiterate. You are always better off to assume they know nothing. It is better to say, I'm going to assume that you don't know anything about these medications, and I'm going to explain them in depth. Because people, by far and away, are medically what I call illiterate. They're not stupid people. They're very bright, smart. They could be, scholars. But if they're not worldly of, have a lot of knowledge of medicine, they don't understand. This is your time to say, this is the medicine I'm giving. This is the drug class. This is the why. It is so important that you take it. These are the things I'm expecting to see. These are the side effects I do get worried about. This is how often those side effects tend to happen. This is what I want you to do if you have those side effects. This is about how much the medication costs. This is how long you're going to be on it. This is how many refills you get or you don't get. This is why I'm doing the refills this way or that way. I'm starting at this dose, but my goal is likely this next dose, but I start low and I go slow. So, over the next 4 months, my plan is to get you to this next dose, et cetera, et cetera, et cetera. This is the why and the how. You have to do that for them. The medication education is how you're going to promote the best outcome. Okay? If they don't understand it, if they don't know why, and they don't believe you, they're not going to get the drug. They're not going to do what you've asked of them. It also allows you this chance to provide rumors, or to dispel the rumors, not provide them, dispel them, about the medicine, right? I say this sometimes with things like diabetic medicine. Or sometimes I'll say, this is metformin, this is the drug I'm going to start with, this is the da-da-da-da-da, the why. You may hear about these new fancy drugs out there, like X, Y, or Z, and you may get on those eventually. But my plan is we start this. This is a safe drug. This is the whatever. I talk about that, those kind of things. The other thing is it helps reduce medication errors on your part and on their part. Very important to stop and take the time to educate your patient about the medication. And then you document. I gave them this education. We discussed risks versus benefits. We discussed adverse reactions. We discussed monitoring. We discussed length of treatment. We've discussed all of these things. I put that in my notes. Okay. Again, the medication name, I do tell them this drug has 2 names. You may hear it called this, or you may hear it called this. The trade name is Toprol XL, but the generic name is metoprolol succinate. They're the same drug. I write for metoprolol succinate, but if you hear the word Toprol XL, they're the same thing. Okay? Your purpose, why you're having them take it, what effect you're looking for, how they're going to know if the drug's working or not working. Sometimes I tell them, you're not going to feel a thing, hopefully. I don't expect you to feel any different right away, or I don't expect you to feel different at all. You'll probably not even notice you're taking it, whatever the case may be. The regimen, administration, adverse effects, special storage needs is incredibly important. Think of the things like insulin. You can't pack it in your carry-on and let it get super hot somewhere. There's drugs that require special handling and care. Associated labs and testing, how often those are going to be, how much they're costing, if we know that, those things. Food and drug interactions are very important. And then the duration of therapy. This is why we kill trees still with our electronic health record, is because we also need to give written instructions. I can verbally tell you, I can put it in your electronic chart, but they also need a written one. Oftentimes in your encounter with a patient, they receive so much information, they can't remember it all, number one. So the written things are very important. And then a month later, 2 hours later, whatever the case may be, then they can say, got it, I can see what I'm supposed to be doing. Make sure that what you're writing is important. You want to limit the content to the important things. Place your important content first. Write in an active voice, like you will be taking, not the patient, right? You will be taking 1 pill each morning when you wake up on an empty stomach. You will wait 30 minutes before you eat or drink anything besides water. I mean, you will, those kind of active voice. Include adequate white space. Use meaningful illustrations. Avoid too much professional jargon or terminology, and then make sure they're readable. Monitor for positive and negative patient responses. Act on findings in ways that increase the benefit or decrease the risk. There should be a plan for follow-up. 3 primary reasons for drug monitoring is to determine the therapeutic dose with a lab test, evaluate medication adequacy, or to identify adverse effects, such as kidney functions going up or something like that. And then again, adherence is the extent to which the patient will take their medication as prescribed by the provider. Lack of adherence can lead to worsening symptoms, exacerbations, avoidable hospitalizations, transitioning to long-term care, and death. Factors that we already talked about that. We know this when we interview patients. It's forgetfulness, lack of planning, cost, dissatisfaction, or altered dosing. Periodically review patient's medication therapy regimen. This is a huge one. And again, kind of a soapbox topic real quick. It is utterly important that you as a prescriber, you know what your patient is taking. Okay? What do I mean by that? If you are having your nurse or your MA or your LPN or your somebody verifying patient medications with the patient before they come into your interaction. So if you're in an outpatient heart failure clinic, for example, you are trusting your MA, your LPN, your RN, your whomever, that when you get this med list, they have verified this is the correct med list, right? Okay. You are responsible for it. So if you don't hammer it into them, if you don't trust them, if you think they're lazy, you think they're skipping steps, that all still falls back on you. You have to ensure that they understand why that med list is so important. I argue that darn near every interaction you have with the patient, you reviewed their med list. So maybe you just saw them 5 weeks ago in heart failure clinic. I don't care. You renew and review their med list, especially when they're 80, 90 years old, you guys. They go to urgent cares, they go to walk-in clinic, they go to those things. It is worth it to say, Mr. Smith, I just saw you 4 weeks ago, but has there been any other changes? Have you been to a walk-in clinic or an urgent care? Have you had any hospital stays that I don't know about? Anything changed? No? Okay. So I'm going to go through it again. I know every time, and you make a joke about it. And if they get snitchy with you, you say, this is for your safety. I do this with all of my patients, and you stick to it, and you do it. It is huge. One of the biggest mistakes that happen in an inpatient setting is that we do not adequately or appropriately review their medication list. It will become the bane of your existence and the thorn in your side. It affects everything. If you talk about how you can screw up somebody's healthcare, screw up their home med list. If you guys ever want to do a project, go and do a deep dive into how much medication errors there are directly related to reconciliation of a med list. If you don't put it in the right way, if you put garbage in, you get garbage out. That is so very true. You screw up their inpatient orders, you screw up their discharge instructions, you're confused, they're confused, their primary care is confused. It creates chaos. So that's my quick little soapbox. Please, from here on out, pay attention. Start asking what unit you're on or wherever you're working as an RN. What are your processes to ensure that that medication reconciliation is done appropriately? Do you trust those people? Is it reviewed? What education does a new nurse or MA or somebody get up on being a new hire? How are you guys assuring that that process is being done? And then also remember, is the medicine achieving what you want it to achieve? Because we can get to a situation of polypharmacy very quickly when no one is reviewing the medicine. Why are you on this? How long have you been on this? Is it still working? Is it achieving the desired effect? Do we still need this? And you would be amazed, especially when people are 60, 70, 80, 90 years old, how many medicines they just stay on because I have been on it forever. That's the answer you get. I don't know. I've been taking it for years. Okay, well, maybe let's take it off. Do we need it? Like, things change, right? An example of this would be someone who's 90 years old continues to take his Flomax every day, although he has had an indwelling urinary catheter for retention for 9 months. He's got a Foley. He's never not going to have the Foley. It's just going to be in. Everybody's accepted this fact, and he's still taking Flomax, okay, which is tamsulosin. Absolutely something that is ridiculous to take that. It has risks of side effects, you guys. If you read tamsulosin side effects, they are there, and I have seen them. They are there. They exist. So now you're just having this man take this medicine day, and day over again and out, over and over and over, for no reason, you guys, because nobody is looking at med lists on some of these people. So that's my soapbox. This is chapters 1, 2, and 3. Please reach out with any questions or concerns. These are pretty simple, basic chapters. I hope these points come across well to you. And again, please let me know if any questions or concerns. Thanks.